I have kind of an awkward transition to make because the movie you just saw obviously is about patients with very severe form of ME. The patients that I work with are less severe, and some of the data that you're going to look at, I think those of you that are familiar with patients that have severe ME, you're going to look at them and go, boy, is that the same illness? And I would suggest yes, it's on the same continuum of the same illness, and I think some of the insights that I'll share with you tonight inform the pathology for those that are more capable as well as those that are less capable. The title of the talk is a little play on words because I think there's a word that we use a lot in the States, chronic fatigue syndrome. That's the word we use to describe ME. And the word fatigue often comes up a lot as being a very subjective symptom. It's a self-reported symptom. Oftentimes people, when they talk about, and I'm sure all of you have heard this before, when you talk about someone that has ME or chronic fatigue syndrome, someone will say, oh, I'm tired all the time, I have that too. And you want to look at them and go, you have no idea what we're talking about. And one of the things I'd like to share with you tonight is how the exercise testing may be able to provide an objective view of fatigue, what it truly means when someone says chronic fatigue syndrome, that fatigue could be objectively viewed. And that's the reason for the title, An Exercise in Objectivity. And it's a realistic approach both to viewing the symptoms of ME and then perhaps being able to find ways of managing that care. Just to give you a little bit of history, I work in a Department of Health and Exercise Science, and as exercise scientists, we're used to viewing exercise as a way to ameliorate disease or to cure disease, and I think there's an underlying notion that the harder one works, the more benefits that they see. And as we go through this, you'll see that effort perception may not have anything to do with the type of what we call analeptic exercise therapy is very different than what most people would regard as exercise, but in fact it can be useful in helping to treat the illness. I helped with the Ampligen studies that both Stacy Stevens and Chris Snell had started out with back in 1999, and these were the first studies that were using. Ampligen was a drug from hemispherics that was used to treat patients with ME, and we used the results from the exercise test in an attempt to quantify whether the patients had gotten better or not. So some of this stuff I'll share with you tonight uses those similar protocol. We used to have a Pacific Fatigue Lab at the University of the Pacific, and that's been moved to Ripon, California, and it's called the Workwell Foundation. And the branch that does the exercise testing is Workwell Physiology Services. I have a picture of our lab here, and the reason I show this is because I want to illustrate that it's not a lot of sophisticated machinery. This is the entirety of our data collection apparatus. You see a very typical exercise bike that's used for doing graded exercise. The expensive equipment here is a metabolic cart, and you can see here's a patient that's connected to the metabolic cart. The air that she breathes out is being analyzed for how much oxygen is being utilized from the air that she breathes in and how much CO2 is produced. And from that we can tell a lot about what's happening metabolically inside the body. She's fitted with electrodes here, and the electrodes just monitor the rate and rhythmicity of her heart. And so it's typical to use this as a cardiac stress test. We add the metabolic part, and we refer to this as cardiopulmonary analysis. And some of the abbreviations you'll see in the literature, CPX for cardiopulmonary exercise or cardiopulmonary exercise testing. This is very different than GET, which you'll see sometimes in the literature, graded exercise therapy. We're not doing graded exercise therapy here. We're using an aerobic exercise test to help measure the degree of functionality for the patient. I want to give credit to Stacy Stevens, who's been kind of the brain trust of the whole Pacific Fatigue Lab and Workwell Physiology Services. And a lot of the data that I'm going to show you, Jared has collected those data. We often are asked by people, couldn't we set this same kind of thing up somewhere else? And this equipment is very common. The one thing that's not common are the people that run them. They're very sensitive to the needs of people with ME. And running an exercise test is not challenging or difficult. It's just understanding the illness so you can collect good data from them. Here's some of the insights that I want to share with you tonight from our exercise testing. The first insight that we found is that We've all heard of post-exertional malaise. It's a characteristic of ME. And I think the results from exercise testing shed a lot of light on that in a new way, and perhaps a way that could be useful for other research paradigms to look more accurately at post-exertional malaise in ME. I just want to show you some data that shows very clearly aerobic energy pathways in ME are severely impaired. So much so, I mean, I use the word substantially impaired, so much so that it does not justify trying to fix a broken system. In other words, trying to do aerobic exercise therapy to fix a system that's broken doesn't make sense. Therefore, therapeutic interventions that are focused on lifestyle changes, doing healthy physical activity, would avoid activity that relies primarily on the utilization of oxygen. So hopefully some of those things will be clear from the talk. You guys know the diagnostic criteria for ME follows a list of primarily subjective symptoms, and one of the things I want to show tonight is some of those subjective symptoms can be objectively measured, and that's very helpful in determining the degree of disability that a patient with ME experiences. And I think that's important not just for the individual to classify how impaired they are or the progress of the illness. It can also be important for two other reasons. One, if there's a therapeutic intervention that should alleviate fatigue, then that should be able to be objectively identified, not just through subjective symptoms. And I think objectifying fatigue can be useful for those that may not be able to work. Having proof, like for instance, for those that have lost insurance benefits or seeking disability, it's nice to have an objective view that's not just relying on the input from the patient. I put up our Centers for Disease Control and Prevention in the United States relies on this characteristic of post-exertional malaise. We've used for a lot of our studies the Fukuda definition, and we've embraced the Canadian case definition much more so, simply because the post-exertional malaise seems to be a characteristic of ME that's important to us. This is showing Stacy. This is a lab that we set up at, in Salt Lake City, where we used the results of an exercise test as what we refer to as a standardized stressor. There's this phenomena that everybody knows in ME, where patients have good day, bad day. You saw him talking about it in the movie. When you have a patient that's not in the midst of an exacerbation, sometimes they can appear very, very normal. They can carry on conversation, they can do things. We even had a disability case where someone was videotaped going to church. And they, of course, said if they're well enough to get up and walk in and sit at the church, they must be fine. What they did not see is that person needed Monday, Tuesday, and Wednesday sometimes to recover from that. And so we think subjecting subjects to this standardized stressor may be a very good way to get an objective view of the illness in its most acute way. Not just objectively, but as we mentioned before, being able to monitor the activity and rate rhythmicity of the heart gives us both cardiac, I mentioned the pulmonary and metabolic assessment. I think that's very informative to understanding the pathology of the illness. You saw in the video where the one mother said, every system in the body appears to be impaired, or at least affected by the illness, some at different levels than others. Sometimes we have what people have described as heart failure in the absence of heart failure. And so patients that have primarily cardiac dysfunction during the exercise test may need to be treated different than those who either have ventilatory, pulmonary, or in fact, metabolic assessments. I was sitting down with Dr. Booth tonight presenting he has some very compelling data on the metabolic system that matches some of what we've seen in patients as well. This can be very helpful for disability classification and for post-exertional malaise. So the first insight, significant post-exertional symptomology. Here's the take-home message from this. ME patients can take a very long time to recover from aerobic exercise. I just wanted to point out here, the treadmill test that we did to generate these data is only 5 to 10 minutes of walking on a flat treadmill and then a steepening grade on a treadmill. Most of the control subjects that do this, they experience a little bit of what they call fatigue right afterwards, and they usually feel fine the next day. Patients that have undergone this have sometimes reported up to 7 days to recover from a single bout of exercise. So clearly, there's an abnormal recovery response to aerobic exercise. And not just the typical things that you would think, that their legs felt tired and sore, a lot of very diverse symptoms, including musculoskeletal, neuroendocrine types of response. This just gives a good example of this. This is an exercise recovery questionnaire that we give. This happens to be from one where we did a first exercise test and a second exercise test. These are the responses here. It's cut off a little bit on the bottom. This is from one of our control subjects who did 2 exercise tests. And she said she felt a little bit sore and tired, a little bit tired the day after the exercise test. But then listen to this. She even felt a little energetic, and the day after the second exercise test felt great. This is a very characteristic response, legs tired. This is the response from a typical ME patient. And if you look at some of the symptoms that are portrayed here, they go beyond just delayed onset muscle soreness, nausea, lightheadedness, headache, legs so tired they have difficulty moving, shaky down here, hip and joint pain. We looked at this a little bit more closely in one of our studies, and we like to use this term. Instead of post-exertional malaise, we see post-exertional amplification of symptoms. The graph shown up here shows the kind of symptoms that control subjects complain of after an exercise test and those that patients with ME complain of. And what you see with the numbers down here just refer to these reported symptoms: fatigue, lightheadedness all the way down here to difficulty sleeping, and then flu-like symptoms all the way up here. In the dark box is how they felt immediately after the exercise test, the clear box the next day, and then beyond in the days following that. And what you see in the control patients, they experience some of these symptoms, but then the next day and in the days following that, those symptoms go away. What you see in the patients with ME is not just more symptoms, but in the days following, in a lot of cases, these symptoms are becoming amplified. Instead of resolving within 24 hours, they're actually becoming more magnified in the period of time beyond the exercise test. This is clearly an abnormal response and shows something that's happening secondarily to just the bout of exercise. Probably the most compelling data from our lab is the aerobic system is significantly impaired. And this is nothing new. These are some old papers that show that the ability to use oxygen in ME patients is impaired. Dr. Booth's data showed the exact same thing. We did an initial study where we categorized patients according to their ability to utilize oxygen. And these are 4 different classifications that come from our American Medical Association that allows us to classify patients according to how they perform on an exercise test. And you can see of these 160 or so patients, a number of them are classified as moderate to severe functional impairment simply based on their ability to utilize oxygen. And we asked the question, how come some of these appear so good, whereas others appear so poorly? And I think a lot of that has to do when you do a single exercise test. Some patients would rest up sometimes for a week before, and so they could come in and perform well. Others, just the act of getting to the clinic to do the exercise test was stressful enough to where it impaired their ability. I'm going to skip that one, but this just, based on that idea, we came up with what some of our CFS patients have called the ultimate torture, but they come in and they do an exercise test on a day that they've rested up. And presumably, they're going to be able to perform at their best. This is what Dr. Klimas would talk about as a good day. They're rested up. They're not in the mix of a post-exertional exacerbation. They're not feeling crummy. And then we see what their performance is on that first exercise day, and then bring them back 24 hours later and test them again in a post-exertional state. And remember, this is not a period of time where they've had this long period of time to amplify these symptoms. This is just 24 hours later. These are some of the original data that we had shown. A significant, the blue here is the control subjects. Their VO2 on test 1, test 2 is no different, which is exactly what you would expect. The CFS patients on day 1 when they came in rested up, indeed, they look normal. They look perhaps detrained, but relatively normal. This response that you see to the second exercise test is a very abnormal response. Biologic variability could be as great as 8%. And in some of these patients, what we're seeing is a reduction, and sometimes as much as 10%, even 20 and 25% in a variable that should be fairly constant. When I first presented these data, many exercise physiologists came up to me and said, your equipment obviously is not calibrated correctly, which is logical. It's only calibrated on the second day, only on the CFS patients poorly. But we did, in fact, rent a metabolic calibrator. We videotaped our calibrations, the metabolic card. We knew it was working fine. It's just hard to accept such a dramatic difference. This is a paper that we just published at the end of last year, and I want to share this one with you because of the analysis we did on some of these exercise variables may be very helpful in diagnosis and treatment of patients with ME. And you guys know in the States, when we use the term chronic fatigue syndrome, we wish we had a better term for that, but we're talking about the same ME that's diagnosed over here. We used a lot of patients with ME, a few controls, and we didn't need very many controls because their data tends to be very homogeneous. They're a very tight group. They produce similar results. Just because of the variability within the illness, we recruited more patients with ME. These happened to be all middle-aged women that had a good, clean diagnosis of ME. They did 2 exercise tests. These are some of the data that we generated. We measured oxygen consumption when they were resting. We measured oxygen consumption continuously until they were unable to do any more work. And one of the criticisms from that last study that I showed you is we compared peak VO2. And a lot of people say, well, who in their life does peak exercise as part of their day-to-day routine? So we looked more closely at a workload that's more representative of how people work, how people live, the activities that they do day to day. And this is called the anaerobic threshold. Some people call it the ventilatory threshold. It's the activity intensity where your body can't rely solely on aerobic metabolism, and so you start relying more and more on anaerobic metabolism. For athletes, they call this exercise intensity the beginning of the end. For patients with ME, the anaerobic threshold oftentimes occurs during activities of daily living. And so we were very interested in what was their aerobic threshold. When we put all of these variables into what's called a multivariate analysis, which is just a statistical way of looking, are the CFS patients different than the controls? Clearly they were. But we analyzed these data just a little bit differently. We did what's called a discriminant function analysis. And a discriminant function analysis basically says, given an individual's exercise data, could we clearly differentiate a CFS patient from a control patient? And what we found, I'm just going to go forward for a second, what we found was a 95% classification accuracy, which basically says, given a group of CFS patients that we did an exercise test, we could clearly say whether they were CFS or not, solely based on the results of the exercise test. So 49 out of our 51 ME patients were correctly classified, meaning 2 of them there were incorrectly classified, and 1 of our control patients looked like an ME patient. And the reason I put this data up here as an important conclusion is because perhaps an exercise paradigm like we've incorporated here could be included as part of the diagnosis to see if they're classified correctly. And some of the things I think is important is that the exercise test may be helpful in helping us understand what activities a patient is capable of doing versus that they would struggle with. And I think some of the measurements at the anaerobic threshold may be helpful. I hate to use this term biomarker because in ME research, we've seen so many biomarkers come and go. And so I'm leery about using that term, but at the same time, it may be helpful in diagnosis and treatment of patients with ME. I just want to focus more on the activities here just to highlight the way we live our life at rest is primarily dependent on aerobic metabolism. As you increase activity, say to stand up or walk around or do activities, aerobic metabolism has to increase its activity, and one of the byproducts of that is CO2. If that CO2 is not rid from the body, CO2 is a very potent acid. And those of you that know the definition of acid, it's something that donates hydrogen ions. When you look at CO2 there, you're like, where's the hydrogen ion? When CO2 combines with water, it makes carbonic acid, which is very uncomfortable, very toxic to the system. If we compare that to anaerobic metabolism, usually more shorter duration, higher intensity activity relies on anaerobic metabolism. And lactic acid is the product of that. Lactic acid, contrary to most people's notion, is a very gentle acid. Actually, lactate can be used as an energy substrate. It's not the kind of thing that produces muscle pain. And Dr. Booth had printed out something to show that to me tonight, just to reinforce. Lactic acid isn't something that produces delayed onset muscle soreness. The byproduct of aerobic metabolism, if it cannot be removed from the system, can be toxic. This is just kind of energy systems 101 here, but what's highlighted is the increased or decreased risk for aggravation of functional impairment in patients with ME. What's shown on here is the contribution of these three energy pathways: the immediate energy system, which we call the phosphagen system, the short-term system, which is non-oxidative or glycolytic metabolism, and then this long-term energy system relies on the delivery and utilization of oxygen. And most activities that go beyond about 2 minutes in duration rely heavily on this long-term energy system. And when you rely on this long-term energy system, which shown here illustrates the deficit that you normally see with ME, that you're going to have increased risk for aggravation of capabilities if you rely on that system. So a lot of what we focus on when we're working individually with patients is how do you get people to rely more on shorter duration activities that rely on a system that can be trained and can be utilized for activities of daily living that use the short-term energy system. The therapeutic interventions that are oriented to this rely much more heavily on these anaerobic energy systems and try to avoid activity that creates an oxygen deficit. I'll show you a credit card example here in a minute that I think makes a little bit of sense, but just let me share with you a case study. This was from a woman that lived on a third-floor apartment. And for her to get out of her apartment, down the stairs, and to shopping created very significant post-exertional symptoms. She said, I'm unable to go downstairs without having post-exertional malaise. And her goal was, is there any way I can get up and down these stairs? And in her head, she was thinking, can I retrain my aerobic system to allow me to walk up and down stairs so that she doesn't experience as much post-exertional malaise? And you can see some of her symptoms, sleep dysfunction, obviously common, muscle aches and pains. And then what we tried with her is a series of anaerobic activities, and I'll share you the findings of her outcome just a little bit later. We started her, like we do many of our patients, on understanding energy conservation, which most patients understand already. This just helps them gain a little bit better control over that. A term that I'm going to focus on in the brief time tonight, analeptic exercise. It's not aerobic exercise. Analeptic is a word that means much more restorative. It's a bout of physical activity that will increase capacity that is restorative. And we find when we can provide this energy conservation and analeptic exercise therapy, it provides the patient with a bit of measure of control over their illness, and so they don't feel at such mercy of the illness when they understand it a little bit. And again, it's an exercise bout that is designed to be restorative. If you have a bout of exercise that's not restorative, something's wrong. You heard Leonard Jason in the movie talk about how patients with depression, when they do aerobic exercise, they get better. And because aerobic exercise helps people that are depressed. Patients with ME may have some secondary depression, but doing aerobic activity exacerbates symptoms. Not only does it make ME worse, it also makes their secondary depression worse as well. This is something that needs to be done away with completely. This is the kind of thing that exercise physiologists, physical therapists, occupational therapists, push yourself harder and you'll have bigger gains. Put a big X through that. What we're talking about here is functional movements that are restorative in nature, that are focused on training that anaerobic energy system, the one that's still functionally intact, the one that can be utilized to do activities. And the goal here is to improve range of motion and functional strength so that you can do activities of daily living. I just share a story with you about a woman that came in for the exercise test. She was a marathon runner before she got ME. And she was certain that she could retrain herself. She wanted to do the exercise test to find out what her heart rate was as her anaerobic threshold so that she could go back to doing aerobic activity. And after she left, she started a very rigorous aerobic training program. And in order to do that, as you guys know, she had to cut a lot of other things out of her life to accommodate the energy that the running took. And after 6 months of very dedicated training and attempting to recover from that, she came back to the lab. She did another series of tests, and after all that training, she found she was actually worse. And I think, like we said, this is a continuum of the same illness. That very dedicated, high-functioning ME patient trying to retrain a system that's broken doesn't help. So what we focus on is trying to improve quality of life, and in the process, have a coping tool that helps manage illness while leaving room for other activities. These are two extremes we try to avoid, and it seems patients have the tendency to try to embrace one or the other. The roller coaster person, the one that when they feel good, they have those days they feel good, they push themselves too hard, and then they subsequently crash in that push-crash cycle. The ones that have learned to completely avoid pushing them too much are the ones that avoid activity altogether. And we try to recognize not to push too hard to avoid the crash, but at the same time, try to find an activity that doesn't cause that crash and the fear that's associated with doing some sort of restorative physical activity. This is why working out doesn't always work out. This is post-exertional malaise the way most people think of it. An athlete that does a bout of exercise and then feels very tired and fatigued and then recovers. The post-exertional malaise we're talking about with CFS is a very defining characteristic. And we're talking about post-exertional malaise that lasts longer than 24 hours, and it's not just fatigue. Lightheadedness, breathing problems, muscle pains, all of the things that ME patients are familiar with when they push themselves too hard. This is the credit card example that I think ME patients can embrace. This phenomena of oxygen debt and deficit, when you push yourself beyond what you can utilize oxygen for, it's referred to as oxygen debt. And this is the credit card example I would share with you. An athlete would be able to create an oxygen deficit like you borrow money, and the interest rate is relatively low, and so it's easily paid back. Healthy people still have a very healthy ability to recover. Patients with ME are borrowing oxygen at a much higher interest rate. It's much more difficult to pay that back. And this is one of the reasons we, again, try to avoid something that utilizes the oxidative energy system. You see the picture of the stairs over here? How in the world would that woman get up and down stairs if she's worried about creating an oxygen deficit? And one of the things that you can do is break the movement into very short-term bouts of activity. And that can simply mean going up a portion of those stairs, putting a chair on the landing, and allowing yourself to rest and recover so you don't have this enormous interest that has to be repaid. Breaking those day-to-day activities into smaller bouts of anaerobic type activity seems to be easier to recover from. And that requires redefining what we regard as exercise therapy. And that traditional training approach certainly is not going to work. Rather than try to present a program that would work for all people, recognize that one size wouldn't fit all. Primarily, bed-bound patient would be very difficult to do the same kind of activities that you would do with a more high-functioning ME. And so trying to fit what we regard as analeptic exercise to the function and needs, and always matching the program to some symptom fluctuations. Those period of time when you do want to go shopping, you may have to put your physical activity program on hold until symptoms resolve. We try to get physical therapists to ask the right questions. What activities do you want to do? How do you feel immediately after? And always trying to avoid post-activity relapse of symptoms. Again, trying to make the bout of physical activity restorative in nature, and helping redirect goals that are more realistic. Returning to running marathons, obviously, with a broken system is not going to be realistic. We start with 30 seconds. Most people, when they start with a bout of exercise, start with 20 or 30 minutes. Stacy uses the term 30 seconds to better living, trying to focus on something that's attainable, can be accomplished, can provide restoration to the muscles and joints without causing relapse. There's some of the core concepts. I want to just highlight one right down here. I know you guys didn't come for a lecture on exercise, but rest is very crucial. We oftentimes use this ratio of one measure of time that's done doing physical activity, and at least 1 to 3 ratio, long duration recovery, trying to avoid that large oxygen deficit that occurs from longer duration activity. Recognizing you might have to make room for an exercise program in a limited energy envelope, I think is important. I think the data that we show from the exercise tests helps to justify a program that focuses away from aerobic activity and more toward anaerobic and strength training, to help reframe what we regard as exercise that understands physical limitations in patients with CFS. This just shows kind of the stages that we typically follow. Patients oftentimes want to progress rapidly from one stage to the other. In some patients, stretching and strengthening can oftentimes last for a year and can provide very restorative types of movement without an exacerbation of their symptoms. Dose-controlled interval training. The interval training that we're referring to there is very short duration anaerobic type activity, not the graded aerobic exercise therapy that's common with things like the PACE trial. When exercise training does work out, it does provide a feeling of empowerment. When you allow someone to reframe what their idea is of exercise, it can be very restorative. It can improve quality of life. It can give patients a strong sense of self-control over their illness. And then it can oftentimes help the extremes that ME patients may experience for fear that they're never going to get to move again and they overdo it, or fear that they're never going to be able to move again because their symptoms are so severe. This is a workout program for that woman that she started out very, very slowly. She progressed and had to be restrained in her progression because sometimes I think you get a little exuberant when you start seeing good results. After 3 months, she started feeling stronger. After 2 months, she could get up and down her stairs without a serious relapse. She still had to make room in her activity envelope for those types of activities, but it did provide a measure of control and ability to overcome her illness and still be able to do the things that she wants. Both our lab, and you saw Leonard Jason has some studies where he's done case studies. We're going to have one that we present at the IACFS meeting. It's a series of, it's a multiple case study design that does show that some of the exercise therapies can help patients if they learn to avoid exacerbating, utilizing a system that is broken. I think I'd like to especially say thanks for Natalie to putting this together. All of our collaborators have been wonderful in providing these data. I think rather than try to do questions now, we'll wait till the end. Okay. Thanks, you guys.